I think the 5 talks we just heard probably must have given you a roadmap about how to manage heart failure with reduced ejection fraction, especially when there are problems like hypertension or hyperkalemia, or how to change ACE inhibitor to ARNI. And again, when the heart failure worsens despite all the standard 4 medication. I always felt that managing heart failure is one of the most skillful technique required by a physician. And that is a skill of a physician is tested in no other area other than in heart failure management. Because if you are patient and if you are careful, you can save life. And it save life better than maybe many of the interventions we do. So I think there must be many questions about it. Yes, please.
I want to add one point. There are so many physicians here. While we take a patient into the ICU who is in heart failure, we should take a second history to rule out this sepsis, acidosis, then their dehydration status. That is very important. Many of the physicians nowadays are very prompt in writing inotropes. And I used to see case sheets with noradrenaline on the 3rd day or 5th day. That's all very useless, and that patient will be severely hypovolemic. And always take a habit of, the Sultan was mentioning so many things to rule out before jumping into adding inotropes with BP around 90, 60. That's one point. And second point, this hyperkalemia when we are adding all these 4 pillars, usually we used to see around 5.2, 5.5 rather than 6, 7 values. So if we take a repeat value of the same patient may be in sepsis, there will be intolerant hemolysis. So if we repeat the potassium value once again, sometimes the value will be around 4.9 or 5. Don't jump into stop these pillars because these are life-saving. That's all.
So I think we can ask 1 or 2 questions to each of the speakers. Manoj, now there is a tendency where people are on optimal dose of ACE inhibitor or ARB and all the 4 pillars and switching over to ARNI. Many times patients on 10 milligram enalapril twice daily, because of the cost factor, the ARNI dose will be suboptimal. Now, is it a good strategy, or is it because it always happen because of the cost factor? So in that case, do you think that continuing the enalapril will be better than a sub-therapeutic dose of ARNI?
The cost of ARNI has come down a lot. You can get ARNI tablets less than 10 rupees. So if you compare the benefits of ARNI,
so 200 milligram is at least minimum cost is 25 rupees.
You are substituting enalapril with a drug which has got a better cardiovascular benefit, decreases the all-cause death, decreases the hospitalization of heart failure, which produces less side effect like decreased hyperkalemia, better renal profile. So I think cost is not a factor because the cost of ARNI has come down. I think it's comparable.
Thank you. You made the point. Right.
Even if you target 50% of the targeted dose, you have almost near similar effects. So I think we should target even if you are not reaching 200.
But already the patient is already on a maximum tolerated enalapril. We don't have data for that.
Now, what I am saying is, even if you don't achieve the maximum dose of ARNI, achieve the half the dose.
That's right. But this patient is on maximum dose of enalapril already. That is the question. Even then, half doses, but we don't have data for that.
So, Paradigm Heart Failure was one of the trial where they have achieved the maximum dose of enalapril. So, you still have benefit of giving ARNI in patient if they are taking
half dose.
Yes,
Paradigm Heart Failure, they use the full dose.
I agree, sir.
200 milligram twice daily. Okay. Regarding the hypotension, who talked about hypotension? 90 by 60 BP? Yes. Do you accept, because many of our heart failure patients are optimal medical patients, medical asymptomatic, but they have BP of 80/50. And then immediately the doctors are threatened, frightened, and then asked to stop. So what will you recommend in a patient asymptomatic but blood pressure is 80/60?
If there is no signs of systemic hypoperfusion, patient is asymptomatic 80/50, we do not need to modify the drugs. The patient's perfusion status should be assessed. If it is okay, no need to modify.
Okay.
Will you increase to 100? Your patient was on 50 milligram RNA.
Yes, sir. In that case, I actually did not have time to discuss. In that case, patient was not on optimal drugs. I should have changed nitrates to non-nitrate anti-anginal drugs.
And one more point.
That will help in increasing the BP, and I can increase the doses of beta blocker was suboptimal, RNA was suboptimal. That changing from tamsulosin to other agents will also help. Seeing for other factors, especially the diuretic dose, it's on the higher side. All these will help me in increasing the doses of GDMT.
All the critical care guidelines, they don't check systolic BP and diastolic BP. They used to check mean BP. MBP 65 is the cutoff, and we shouldn't check the 90/60. It's gone. All the critical care guidelines is sticking on 65 as the mean.
We still go for the SBP.
Okay. Do you want to ask any question to the person who's talked about worsening renal function? Who talked about? Yes, please.
Vivek,
You want to-
excuse me.
Okay.
To Vivek, I have a question. Vivek, I am Austin. While a patient is on follow-up, if you detect a new renal dysfunction, beyond what percentage of reduced ejection fraction you will consider an aggressive heart failure management? What percentage of reduced ejection fraction number you will consider treating heart failure to expect an improvement in renal dysfunction?
The LVEF of less than 40%.
That is what I was. Okay.
EF of less than 40%. So we go for treatment of
Okay.
aggressive treatment.
Okay.
with
When a
all the
patient
treatments.
is on optimal medication with including ARNI and the creatinine goes up at what level? From 1.8, that was the cutoff in the history in this patient. Suppose it goes to 2.5, what will you do?
So that is a increase of more than 30% of the serum creatinine. So definitely we need to cut down on the RNA as well as the MRIs. Say. And
You will
continue the SGLT2
reduce
inhibitors.
both, or why should you reduce the MRA, because there's no
So,
hyperkalemia?
See, even for MRIs, the cutoff, there is a cutoff of EGFR of less than 30%. So if the EGFR is less than 30, even if the creatinine is more or less, we need to stop or temporarily withhold. And once the creatinine is stable, we can think of restarting it.
Okay. Then, yes.
Yeah, there is recently a lot of talk on gut microbiome. Microbiome changes and pro-inflammatory markers in heart failure and causing worsening of it. Any comment on that?
The question is to whom?
Anybody can answer. Gut microbiome, influence of that because of the pro-inflammatory
What is
markers.
the practical application? What can you do? What can the physician do? I don't know. I mean,
Okay.
Even one thing we missed was the use of ibuprofen. Not in this. Possibly some.
Also somebody, I wanted to ask the last speaker was Sudeep, about digoxin. What is the current status of digoxin in severe heart failure? Because now we have forgotten this drug, but does it have a place?
No, sir. Actually, the data does not have that much support for digoxin.
Why?
Digoxin, hard endpoints have never reached in.
But
digoxin.
hospitalization is prevented in the
Hospitalization,
largest randomized controlled trial of digoxin, after that no study has come.
No study
That
has come.
showed that probably a 0.125 milligram of digoxin half a day in patients with heart failure with reduced ejection fraction reduces hospitalization for heart failure. You won't consider that in at least some patients?
In some of the patients, sir.
Sir, actually digoxin is not out of the GDMT of the treatment for heart failure. If after your all measures of heart failure in worsening heart failure, it's an add-on therapy. and it is recommended for treatment of patients in heart failure with AF. It helps in controlling
That
the
is-
AF.
that is
that is
taken.
also there, and also in worsening heart failure we can use an added.
Okay, and what happened to
There
our,
was an increasing mortality in non-F heart failure. That was why I think digoxin is,
that is the ad hoc study, ad hoc analysis of the DIGI trial. The problem is that dosage of many patients in the placebo people did not receive digoxin, and secondly the dosage now recommended is not the 2 milligram but 0.8 milligram per day. Okay, blood level, sorry. What any role for that the nitrate hydralazine combination in heart failure? I think Sudeep Sagar can answer that.
As such, sir, again, there is no guideline-based treatment protocol saying that there is 100% because they have not reached the hardened points as well as
Afro-Asian?
Afro-Asian, yes, but the current guidelines is not
Right.
supported.
So, in patients whom you cannot use
CKD patients, stage 3, those who are not tolerating RAS inhibitors.
Okay.
That is an indication for.
I think there is there is an indication. In very sick very severe heart failure, maybe there is I don't know whether this is true. If the NT-proBNP is very high, Versigard is not recommended. Is it true now?
Yes.
You have pointed it out. Okay.
That's already.
So, any more comment? Yes.
I would like to add something regarding renal failure. Up to 30% rise of the creatinine is acceptable. You won't be worried much about creatinine. It is more, we will be more worried about the potassium. But since Dr. Anthony talked about patiromer and sodium zirconium cyclosilicate, maybe that once these drugs are readily available, we can still continue some of the ARNI and the other drugs. For when the borderline elevated potassium, we can still continue. I'll be more worried about the potassium.
That is, I think,
patiromer and ZS9 are available, readily available.
What about continuing the RNA and MRA on potassium binders, the usual available to us?
I'll be worried about the rise in the potassium.
Okay, so you can still continue
Maybe
with the RNA and ACE inhibitor and MRA, and then a potassium binder which is available and
probably once patiromer is readily
actually
available.
Patinomer, but that is.
The whole idea of bringing the potassium binders was to combine.
The one thing that is the readily available one which we use, actually it is not for long-term chronic.
That is a problem.
And the other thing is the side effects that is associated with the
this
which we use in that is for the acute stage actually. For the long term, actually the trials have been for the patromer as well as this. And the most common that is used for the acute as well as the chronic is the second one, the sodium zirconium silicate.
Okay.
So that's the reason.
Okay, thank you. I think it is a very interesting session. I think all the speakers did very well, and I think we were able to navigate the difficult path of management of a heart failure with reduced ejection fraction. I wish we had more time so that there could be more interaction with the delegates, but that probably the lunch is awaiting you. So thank you very much for the wholehearted participation in this conference, and congratulations to the convener of the scientific event.